from the jugular foramina. It's 9th, 10th, and 11th. It's easily appreciable. All these nerves are passing from the jugular foramen. And then you can see ventrally, more ventrally, there is 12 hypoglossal. From the hypoglossal canal, the hypoglossal nerve is passing. You can appreciate medulla, olive. So all these basically, they are the normal anatomy of the CP angle, which is shown in this diagram. Now we will go to the next one. The next one is basically the occipito-atlanto-axial complex anatomy. It is showing all the anatomy which is having all the ligaments which is passing at that level. Like these are ligaments of the occipito-atlanto-axial complex. So the stability of the occipito-atlantal joint is primarily due to the ligaments with little contribution from the bony articulation and the joint capsule. So first we will discuss the ligaments which will connect the atlas to the occipit and C1. So these are basically the three ligaments. First is the anterior atlanto-occipital membrane. So the anterior atlanto-occipital membrane, posterior atlanto-occipital membrane, and the ascending band of the cruciate ligament. Cruciate ligament is basically having four, like it has superior band, inferior band, and transverse band. So the ascending band, the superior band, the ascending band is the one which is connecting the atlas to the occipit. So the first one is the anterior atlanto-occipital membrane. So what is anterior atlanto-occipital membrane? It is basically the cephalid extension, continuation of the anterior longitudinal ligament, which is extending from the anterior margin of the foramen magnum to the anterior arch of the C1. Then we have posterior atlanto-occipital membrane. So posterior atlanto-occipital membrane, it is connecting the posterior margin of the foramen magnum to the posterior arch of the C1. Then for the cruciate ligament, it is four-sided, cross in shape. So its ascending band is the one which is connecting the atlas to the occipit. Now the next one is the ligaments that are basically connecting the axis, means C2. C2 is having the odontoid process to the occipit. So what are these? These are basically, the first one is the tectorial membrane. In the diagram, if you will see in the tectorial membrane, basically it is having two parts. One is the superficial part and the other one is the deep part. So the tectorial membrane, the superficial part of the tectorial membrane, it is the cephalic continuation of the posterior longitudinal ligament. This is a strong band which is connecting the dorsal surface of the dens to the ventral surface of the foramen magnum above and dorsal surface of the C2 and C3 bodies. So this is basically connecting like from the dorsal surface of the dens to the foramen magnum above. Its accessory part, the deep part, it is not longitudinally arranged. It is little bit laterally arranged, which connects the C2 to the occipital condyles. This you can see this one, the second one, the deep part, the deeper portion, it is more prominent in the figure 1.12. In figure 1.12, you can easily see that on the lateral side, these are the accessory deep portions of the tectorial membrane. Now, the next ligament is the alar ligament. What is the alar ligament? It is also known as the check ligament of the odontoid. Now, this alar ligament has two portions. Basically, one is the occipito-alar portion. The second one is the atlanto-alar portion. So the occipito-alar portion, it connects the side of the dens, as the name suggests, from the dens to the occipital condyle. So it is called the occipito-alar portion. And the atlanto-alar portion, it connects the side of the dens to the lateral mass of the C1. So these are basically the two parts of the alar ligaments. Now there is one more third, which is basically connecting the apex, apical odontoid ligament. What is it doing? It is connecting the...
Apologies, Dr. Ali. I don't know. Welcome, Dr. Mohaneng. Please, can you help Dr. Ali share your screen if you have since you have the Greenberg with you, so that we can realize. I can't share now right now because I'm on call and I'm not with my laptop, so I can't do the sharing. So I don't know if you can. Thank you.
I have the book, but I don't know how to share it. I have his the soft copy of the book. I have in my mobile, this mobile. 1 minute.
Okay, thank you very much. Dr. Manaki has helped us to share. You can go ahead. I'm sure we can just continue like this. Thank you, Dr.
Yes,
Manaki.
yes, 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 yes. Thank you so much. Yeah. Yeah, yeah. In this
Thank you.
diagram, it's, yeah. Actually, the figure, can we go to the previous one, 1.13? Yeah, this one, yeah, yeah, 1.13, yes. In this, it's prominent, this one. We can easily appreciate the apical odontoid ligament, which is connecting the tip of the dents to the foramen magnum. It's written over here. So this is basically the apical odontoid ligament. It has little mechanical strength. Now the next is all the ligaments which is connecting the axis to the atlas, like C2 and C1. So these are basically, now we can see in the next picture, the transverse atlantal ligament tal. See, it's very prominent here. They have shown this tal. This is transverse atlantal ligament tal written. Now it is usually called as a transverse ligament, the horizontal component of the cruciate ligament. It attaches, how it is attaching? It is attaching it is showing the medial tubercles of the C1. It traps the dents against the anterior atlas via a strap-like mechanism. It provides the majority of the strength, and it is the strongest ligament of the spine. Now the next one is the atlanto-alar portion of the alar ligaments and the descending. And cruciate is basically in the picture, you can see in 1.12. If you will just go back to 1.12, yeah, this is the cruciate ligament. It is showing all the ascending band, the descending band, and the transverse band. So cruciate ligament is having basically ascending, it's connecting to the up. We can see that this is the clivus and to the foramen magnum. Then there is one descending, which is going below. And this is the transverse one, which is connecting, which is basically the tal one. So these are the most important ligaments. Now they're telling the most important structures in maintaining the atlanto-occipital stability. They are the tectorial membranes and the alar ligaments. Because see, the tectorial, as we have discussed before, if we can go in the backward like 1.12, in 1.12, you will see the tectorial. Yeah, see, yes, yes, is this one, 1.12, just above. Yes. You see, on the sides, you can see the side one. It's written accessory deep portion of the tectorial membrane. Basically, tectorial membrane has two parts. One is what? It is the cephalic extension of the posterior longitudinal ligament. That is the straight one going on. And this one, the deeper part, the accessory portion of the tectorial membrane, it is going from the side one. So these ligaments, like the tectorial membrane and the alar ligament also have two portions. One portion is connecting the occipito-alar and the other one is atlanto-alar. So these are basically the sideways, the side connection of the ligament. So they provide the more stability in maintaining the atlanto-occipital stability. Without these, the remaining, the cruciate ligament and the apical dental ligament, they are insufficient. So these two are more important for us. Now we will come to the spinal cord anatomy. Now I want picture number 1.15. Now we will focus on picture 1.15. Yes, that's it. See, the first thing in this picture we need to appreciate is dentate ligament. On the side, they are showing this is the dentate ligament. This dentate ligament is basically the extension of the pia mater. The dentate ligament separates the dorsal and the ventral roots in the spinal nerves. The spinal accessory nerve, which is the 11th nerve, as we know that it has a cranial and the spinal roots. So basically that 11th nerve, it is dorsal to the dentate ligament. So dentate ligament is separating the spinal nerve into ventral and dorsal segments, sensory and motor. Now, spinal cord tracks. See, in this picture, we depicts a cross section of a typical spinal cord segment, which is combining some elements from the different level. That is, they are explaining that the intermediolateral gray nucleus, which is the sympathetic outflow, they are telling it is present only from T1 to T1 to L1 or L2, where there are the sympathetic outflow, thoracolumbar outflow. It is systematically divided into ascending and descending halves. However, in actuality, ascending and descending path, they coexist on both sides. But to simplify it, we have just divided into it like this. Now, first of all, we need to understand about the gray matter. This picture is showing us gray matter and white matter both. So first we will depict some of the lamina according to the scheme of Reeks. So you can see this gray matter is divided into Reeks lamina like 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. So now they are telling the lamina 2. The lamina 2 is basically equivalent to the substantia gelatinosa. And 3 and 4, they are like the substitute of the nucleus pulposus. And lamina 6 is located in the base of the posterior horn. So they are telling 2 is equivalent to substantia gelatinosa, 3, 4 is like this nucleus pulposus, and 6 is at the base of the posterior horn. Now, first of all, we will focus on one side. Now you can see how we will start. We will start with the numbering. As we can go on the right side, the blue side. The blue side, you can see that there is numbering. 1, 2, 3, 4, 5, 6, 7, and 8 is combined, combination, bidirectional. That we will discuss afterwards. We will start from 1. See, the one is basically we have two type of corticospinal tract. One is anterior corticospinal tract. The other one is the lateral corticospinal tract. So one which is in the anterior half, that is called anterior corticospinal tract, and you can see the last one, sixth one, that is the lateral corticospinal tract. These are basically the pyramidal tracts. The other ones, they are the extrapyramidal tracts. So both of them, their function is to control the voluntary skilled movements. Okay. Now, what is the difference? Now we will, when we will discuss the literature, we will understand that what happens in this one, uh, in the anterior corticospinal tract. The terminal fibers of this is uncrossed tract. Usually they cross in the anterior white commissure to synapse on the alpha motor neurons or on the internucleal neurons. The minority of the fibers do remain ipsilateral. Also, an anterior corticospinal tract is easily identified only in the cervical and the upper thoracic region. They are trying to explain us that what happens that when there is pyramidal and extrapyramidal tract. So the corticospinal tract is basically the pyramidal tract where there is decussation at the level of the medulla. So the one which gets 75% of the fibers, they get decussated at the level of the medulla. The one which get decussated at the level of the medulla, 75%, they will form the lateral corticospinal tract. And the one which are undecussated, 25% of the fibers, they will form the anterior corticospinal tract. So these anterior corticospinal tracts, which are not decussated at the level of the medulla and which are just coming directly from the corticospinal tract, they will get decussated at which level? At the level of the spinal cord, where they will reach. When they will reach at the level of the spinal cord, then they will get decussated at the level of the anterior white commissure. And then they will go from the anterior horn cell at that level of the spinal cord and they will supply. So that is the point they are trying to explain us, that what is the difference between lateral corticospinal tract and what is the difference between the anterior corticospinal tract. And basically the motor, as we know, that these motor pathway, they are having only two order neuron, upper motor neuron and lower motor neuron. Upper motor neuron, basically they are arising from the cerebral cortex, from the motor side, which we know that that is the Brodmann's area 4. From the cerebral cortex, they will pass from the through the corona radiata, through the internal capsule, they will come to the midbrain crus cerebri, then through the pons at the level of the medulla, and basically at the level of the medulla, through the pyramidal tract, 75% will decussate, 25% will be undecussated, 75% which will get decussated, they will continue at the lateral corticospinal tract, and the one which will get undecussated, they will be completely simply they are coming, and then they will decussate at the level of the anterior commissure through synapse on the alpha motor neuron, and then they will go to the opposite side. So that is what they are trying to explain us. That's why they will supply the opposite side of the body. But the lateral corticospinal pyramidal tract, they already decussated at the level of the medulla. So then they will come directly below, and then they will supply to the same side of the body. This is what they are trying to explain us. One more thing, from the cerebral cortex, when these corticospinal fibers, they are coming, they are of two types. One is the corticospinal tract, the other one is the corticobulbar tract. And what is the difference between corticospinal and corticobulbar tract? Corticospinal tract is basically supplying from the cerebral cortex to the spinal cord, and bulbar will just decussate at the level of the brainstem, and they will continue at the lower motor neuron will continue at the level of the these cranial nerves nuclei. So these are basically the differences. Now the next one is the these were all the pyramidal tracts. Now we have the extra pyramidal tracts also. Now, what is the function of the corticospinal tracts? Mostly they are just concerned with the skills movement, the voluntary skill movement as it is showing. The other one, the extra pyramidal tract, they are basically concerned with not the voluntary movement, but the involuntary movement moreover. So what are these tracts? They are showing that this is medial, the two. The second one is the medial longitudinal fasciculus. Then they are showing us the vestibulospinal tract. See, the name indicates vestibular. And what is the difference? These tracts which are extra pyramidal, these tracts are basically not arising from the cerebral cortex. They are arising from the brain stem, the different levels of the brain stem. Like vestibulospinal tract, as the name indicates, it will arise from the vestibule, the vestibular nucleus from the cerebellum, and it is getting input from the cerebellum. So this vestibulospinal tract, it basically facilitates the extensor muscle tone. Then we have reticulospinal tract. Basically, there are two types of reticulospinal tract. One is the pontine and the other one is the medullary. So they are showing that the medullary reticulospinal tract, basically it is concerned with the autonomic respiration. Then we have rubrospinal tract. It is concerned with the flexor muscle tone. See, we have two. One is the vestibulospinal tract. The other one is the rubrospinal tract. The vestibulospinal tract is basically concerned with the extensor muscle tone, and the rubro, from the red nucleus it is arising. Rubrospinal tract. So it is concerned with the flexor muscle tone. Then we already discussed about the lateral corticospinal tract. Now we'll just go through the little bit literature. See, they are telling the lateral corticospinal tract, which is also known as the pyramidal tract, it is the largest and the most significant motor tract of the spinal cord, which is also referred simply as the corticospinal tract, even though there is also an anterior corticospinal tract. So we have two, anterior and lateral. It consists of the large axons of upper motor neuron, which is the bed cells that originate in the motor cortex, precentral gyrus, in a somatotropic organization. The nerve fibers passes through the corona radiata and then through the posterior limb of the internal capsule. Still, when they are passing now, so somatotropically, they are organized in the same fashion. The corticospinal tract progressively loses its somatotropic organization as it passes through the cerebral peduncles and basis pontis. About 10% of the fibers, they enter the ipsilateral, means same side of the anterior corticospinal tract, whereas the remaining fibers, they cross at the medullary decussation and continue. See, the one who had already the medullary decussation done at the level of the pyramid, they continue as the lateral corticospinal tract, along with some fibers which are coming from the supplementary motor area also, which is the Brodmann's area 6, and they have input from the primary somatosensory cortex also. So all these input the sensory information, they will gather up and then they will form the anterior and the lateral corticospinal tracts. Contrary to the classic teaching, which was the corticospinal tract is somatotopically organized with cervical fibers located medially and thoracic and lumbar fibers situated progressively more laterally, evidence shows that the motor fibers of the corticospinal tract in the spinal cord, they are diffusely distributed. Unlike the situation with the sensory tracts, that the spinothalamic, the gracilis cuneatus and fasciculus, which we will discuss, axons of the corticospinal tract terminates on the alpha motor neurons, lower motor neurons, and the ventral gray horn of the spinal cord. See, they are telling that basically what happens, what we think, what basically the concept is that when we will discuss about the fasciculus, gracilis, and cuneatus, so it goes like this: cervical, I'm telling. Sacral is the most medial, then thoracic, and the cervical. See, it's given in the diagram also. Graph, you can see the fasciculus gracilis and the fasciculus cuneatus. So the most medial is the most lowermost, the sacral. This is for the sensory input. For the motor, it's opposite. Its opposite means the cervical should be the most medially. So first cervical, thoracic, and then sacral. So they are just getting emphasis that previously it was like that, that for the motor tracts, the cervical is the most medial, then thoracic and the sacral. But it's not like that. It's diffusely organized in it. Now this was the motor. Now in the same diagram, we will just focus on two bidirectional pathway, which is given the number 7 and 8. See, for the 7 one, it is also known as dorsolateral fasciculus of Lischor's. And the 8th one is called fasciculus proprius. So for the 7th one, for the dorsolateral fasciculus of Lischor, they didn't give any the function, but basically the fibers which are coming from the from the dorsal horn cells and the sensory fibers, they are passing through this pathway. And the 8 number which they have given for the fasciculus proprius, you can see from the diagram that 8-1 is the fasciculus proprius. It is basically covering the whole of the gray matter. This is what? This is just the short spinal connections. Like it is between the just the levels of the spinal cord, like the cervical C6, C7, C8. So it is just connecting the interconnections between the spinal segments. Now these are the bidirectional tracks. Now we will come to the sensory tracks, which is on the other side, which is shown in the pink color. Okay. So in the pink color, if you will start from number 9 and 10, 9, which is more medial, that is fasciculus gracilis. And the other one, the 10th one, that is the fasciculus cuneatus. So you just make a concept in your mind. Just suppose the sacral fibers, they are more medial, then the thoracic, then the cervical. If you will just remember one, the others will be opposite. If you will just remember the fasciculus gracilis and cuneatus tomographic organization, so for the spinothalamic tract and for the corticospinal tract, for the other, all the other tracts, it's opposite. So just remember this one, that this is sacral, medial, then thoracic and cervical. It is like this. So for the sensory one, basically the most prominent, we have 3 type of tract. One is the dorsal column, which is known as the fasciculus gracilis and the fasciculus cuneatus. What it is doing, it is having fine touch, pressure, position, vibration, proprioception, all these things, they are coming by this posterior column. Then we have 2 more. One is the spinothalamic and one is the spinocerebellar. As the name indicates, spinothalamic means from the spinal cord to the thalamus. So spinothalamic tract, it is basically divided into 2. Sometimes it is one also. They have shown in many description that it is basically the anterior lateral spinothalamic tract. But in our diagram, they are showing the anterior and lateral spinothalamic tract separately. So the number 15, the 15 most anteriorly, that is the anterior spinothalamic tract. And if you will go on the number 12 in which it has written CTS, opposite, cervical is the most medial and the sacral is the most lateral. That one is the lateral spinothalamic tract. So for spinothalamic tract, there are two, anterior and lateral spinothalamic tract. Now, the lateral spinothalamic tract is basically what it is doing. It is taking the pain and temperature sensations, okay? And the anterior spinothalamic tract is taking the crude touch. So fine touch, vibration, proprioception, all these from the dorsal column. The crude touch is from the anterior spinothalamic tract, and the pain and temperature is that from the lateral spinothalamic tract. Now, in easy just sense to remember it, the only posterior, the dorsal column, the fasciculus gracilis and cuneatus, they are basically just coming from the periphery. Now we will just read these pathways, but just to understand it, basically from the periphery, from the body, all these sensation, fine touch, temperature, proprioception, they are coming directly to the dorsal column. So whatever, whenever there is some problem, connection will be cut. So it will be on the same side of the body. But for the others, like lateral spinothalamic tract, anterior spinothalamic tract, it will be on the opposite side of the body. So only the posterior column, if you will just remember that that is taking the sensation from the same side of the body, it's enough. For the others, you will just know it is on the opposite side of the body. So dorsal column and spinothalamic tract that we have discussed. Now there is one more thing that is called spinocerebellar tracts. Now, spinocerebellar tracts, basically, they are two. One is anterior, the other one is the posterior. The anterior one is the number 13, which is just lateral to the CTS. Just lateral to the CTS1, that is anterior spinocerebellar tract, and the posterior spinocerebellar tract is number 11. So in front of the dentate is the anterior, and then is the posterior spinocerebellar tract. The other tracks, all these, they are basically having the conscious sensation. They are taking all these. But these, the spinocerebellar tract, they are basically detecting the unconscious, like stretch receptors, what's going on, and in the whole limb position, what, because there are many tendon, muscles, all these spindles, all these. So the conscious sensations, that is basically taken by the spinothalamic tract and the dorsal column. But the unconscious sensations like stretch receptors, like Golgi tendon organ, all these things, all these sensations, they are carried by the spinocerebellar tract. There is one more, which is called 14, which is in between, you can see, which is in between the anterior spinothalamic and the this 13 one, anterior spinocerebellar. In between, you can see number 14, small one. That is spinotactile tract. It is basically carrying nothing but the nociceptive receptors, like the little bit small pain, sensation, all these taken by the spinotactile tract. Now, in order to understand these sensory pathways, basically we have divided into three groups. So we'll go one by one. The dorsal column is taking all the fine touch, pressure, proprioception. Pain and temperature is taken by the lateral spinothalamic tract, and crude touch is taken by the anterior spinothalamic tract. And how it is, like for the motor, we know that there are only two neurons, two order neuron. One is the upper motor neuron, which is coming from the cerebellar cortex, and either it will just finish at the level of the brainstem, or it will continue till the level of the spinal cord. This is the upper motor neuron. And then from the upper motor neuron, they will switch to the lower motor neuron. There are only two order neurons. But in contrast to this, in the sensory one, we have three order neurons: first order, second order, and the third order neuron. So first we will discuss about the pain and temperature. And pain is temperature is taken by the lateral spinothalamic tract. So for these, the mostly the receptors are the free nerve endings. Okay. So first order neuron, in this one, when we are having pain and temperature, the receptors are free nerve endings, and first order neuron are small, finely myelinated afferent fibers. Their body is basically in the dorsal root ganglion, it is present, but there is no synapses. Only the afferent fibers will come in the form of free nerve ending. These are small, finely myelinated afferent fibers. Their cell body will be in the dorsal root ganglion, and then they will enter from the same zone which we have discussed, zone of Lishore. We have seen at the number 7. From there, they will enter the dorsolateral tract. Then they will synapse, mostly these one, pain and temperature, they will synapse in the reeks 2, which is a substitute of the substantia gelatinosa. At this level, they will synapse. When they will synapse, then the second order neuron will start. So these second order neuron axons, they will cross obliquely in the anterior white commissure, which is ascending 1 to 3 segments while crossing to enter the lateral spinothalamic tract. So that's why the lateral spinothalamic tract, it is carrying the opposite, because the first order neuron from the periphery, cell body in the dorsal root ganglion, synapse at the level of reeks 2, substantia gelatinosa. Second order neuron will start. Second order neuron will synapse at the level of the anterior commissure, 1 to 2 levels of the spinal cord, like that, and then they will cross to the opposite side of the to form the lateral spinothalamic tract. This second order neuron will synapse at the level of ventral posterolateral nucleus of the thalamus. From there, as we know, third order neuron will start from the internal capsule. It will go to the posterior central gyra, that is Broadman area 3, 1, and 2. This is for the pain and temperature. Basically, what's happening, the second order, the neurons, it is getting decussated, it is getting switched to the contralateral side. Now, this one is for the lateral spinothalamic tract. That's why whenever there is problem with the lateral spinothalamic tract, the sensation will be lost on the contralateral side. In the contrary, we know that the dorsal column which is carrying the fine touch, pressure, proprioception by the fasciculus gracilis and cuneatus, when there will be problem at this level, always the sensation will be gone on the same side of the body. Why? The first thing is that what are these receptors? Their receptors are a little bit different from the pain and temperature. Pain and temperature, we were just having free nerve endings. In this one, we are having free nerve endings. And then we have, for the pressure, we have Meissner's and Pacinian corpuscles and the Merkel's disc also. So their first order neuron are different from the other one. That one was small, finely myelinated. These are heavily myelinated different. See, for the posterior column and for the anterior spinothalamic tract. Anterior spinothalamic tract is conducting the crude touch, which is the next one. We can do by comparison. The posterior column and the anterior spinothalamic tract, which is conveying the crude touch. Both of them has the same receptors, the same one. Fine nerve endings, Messinian or Pacinian corpuscles and Merkel's disc. Both are having the same receptors. First order neuron of both of them are also same. They are heavily myelinated afferent fibers. Now the body will be same as for all of them in the dorsal root ganglia. Now, what happens? What is the difference between both of them? See, the difference between both of them is that in the posterior one, the short branches, they synapse in the nucleus proprius, that is reached, which layer? 3 and 4. Now, it's little bit anterior. The pain and temperature was just at the level of reeks 2. Now, it is little bit anterior. It is coming to reeks 3 and 4 of the posterior gray matter. Long fibers enter the ipsilateral posterior column without synapsing. Okay, so what will happen? Few of its fibers, only few of its fibers, what will happen? The short fibers, they will synapse in the nucleus proprius at the level of reach 3 and 4. Most of them, what they will do, they will go, the long fibers, they will enter the same posterior column without synapsing. They will continue over up. Now it depends whether these fibers are coming below T6 or above T6. If it is below T6, they will form the fasciculus gracilis. If it is above T6, they will form the fasciculus cuneatus. So it depends upon that which track they will enter at the level of T6. Now what happens? Few fibers, they will get synapse in the nucleus proprius, khalas, finish. The other, most of them, they will not synapse. They will continue at the long. That's why whenever there is any lesion, it will be continuous on the same side of the body. Where they will synapse at the level of the nucleus gracilis and cuneatus respectively, just above the pyramidal decussation. So their synapses will occur at the level of the pyramid. The second order neurons, axons, they will form the internal arcuate fibers, and then they will decussate in the lower medulla as they will form what? Medial lemniscus. Then these second order neuron, they will synapse at the level of same ventral posterior lateral nucleus of the thalamus, and the third one is same for everyone. From the thalamus, they will pass through the internal capsule, and then they will go to the posterior central, post central gyrus, the sensory motor area. Now for the crude touch and pressure, which is basically forming the anterior spinothalamic tract. What is going on? They have same receptors at the posterior column. The first order neurons are also highly myelinated fibers. Their body is also in the dorsal root ganglion. Now what happens? See, what is the difference? Some ascend uncrossed in the posterior column with fine touch. With the fine touch, with the posterior column, they will go like that, same ascending uncrossed. But here it's opposite. Most of them will synapse. There, few of them in the posterior column, few of them they were just getting synapse, and most of them without synapsing, they are just going to the unilateral same track and up at the level of the medulla, they are getting synapse in the nucleus. Now here most of them will synapse, but which reeks in which layer? 6 and 7. They will just come little bit anterior, 6 and 7. Now the second order neuron axons cross in the anterior white commissure like the lateral one. Same exactly like that. They will cross in the anterior white commissure. A few don't cross. They will enter the anterior spinothalamic tract. That's why in the spinothalamic tract, anterior and lateral, they are taking from the opposite side of the body. But the posterior one, because they're going the unilateral, they will just go up at the level of medulla, and then at that level, they will synapse. Now these one, after going crossing in the anterior white commissure, the second order neuron, they will synapse at the level of the ventral posterior lateral nucleus of the thalamus. Then the third order neuron will start. They will go from the internal capsule and they will go to the post central gyrus. Now, can you just change to the next picture? The next picture is 1.16. Can you just move this diagram? Yeah. Yeah, this one. Just wait. Yes, this one. See. Now, basically, this diagram shows us what is the difference between the dermatomes and the sensory nerve. What is the difference? See, dermatomes are basically that area of the body which is supplied by a single nerve root. One single nerve root, the part of the body which is supplied by a single nerve root, that is called dermatome. But peripheral nerve is not a single nerve root. It is basically a contribution, a combination of different nerve roots. More than one dermatomes, when they will combine, they will form the peripheral nerves. So they are telling lesions in the peripheral nerves and lesions in the nerve roots may sometimes be distinguished in part by the pattern of the sensory loss. A classic example is a splitting of the ring finger in median nerve or the ulnar nerve lesion, which does not occur in the C8 nerve root region. So basically, in this schematic diagram, they are telling us how to differentiate between the dermatomes and the peripheral nerve. Dermatome is a single nerve root, and peripheral nerve is a combination of different dermatomes, different nerve roots. On one side, they're showing the anterior and the other side is the posterior. It's very simple. See, the trigeminal has V1, V2, and V3. We know ophthalmic, maxillary, and mandibular. These three, they are supplying the anterior part of the face. Then C2 is basically supplying the posterior part. C2 on the other diagram, and C3 is basically supplying the neck, the supraclavicular part. Now C4 is supplying the supraclavicular as well as the infraclavicular part anteriorly and posteriorly. And from C5 till T2, it is complete upper limb. C5 upper part of the arm, C6 upper part of the forearm, C7 big finger, C8 medial part of the forearm, T1 medial part of the forearm, and T2 medial part of the arm. So from C5 to T2, upper limb distribution, finish. Then we will again come to the body, the trunk. From T3, it will start. T4, we know at the level of the nipple. T10, we know is the level of the umbilicus. L1, we know it is the level of the inguinal ligament. Okay. So L1, L2, then again L3 is the level of the knee joint. Then L4 is the medial part of the leg. L5 is the one which will go to the big toe. And then this complete dorsum of the foot will be supplied by L5. And S1 is the lateral part of the leg. Similarly, we just remember that this S1 is the lateral part of the leg as well as it is supplying the sole of the foot, this part of the sole of the foot. Now, this is the dermatomal distribution of the body. If we will go to the peripheral nerves, we can see it's very easy. If it's a clavicular part, you can see the name, the distribution is superior clavicular nerves. Costal side, it is called intercostal nerves. Intercostal nerves are divided into medial, lateral, and posterior. Medial is supplied by the medial, lateral part is supplied by the lateral, and the posterior is basically supplied by the posterior and the lateral. Now, if you will take upper limb, only upper limb, we know that there is axillary nerves. Axillary nerve is supplying the arm, upper part of the arm, the area of the deltoid. Okay. Now we have radial nerve. Radial nerve basically have, see, it is called, radial nerve has two, dorsal cutaneous and the posterior cutaneous. Posterior cutaneous part, the posterior cutaneous nerve of the radial nerve, it is basically supplying the posterior part of the arm, and a small part on the lateral side of the arm. It is also supplied by the posterior cutaneous nerve of the radial nerve. Then we have dorsal cutaneous branch of the radial nerve, which is basically supplying the back of the forearm. Then in the hand, we know 3.5 and 1.5. 1.5 is supplied by the ulnar nerve, and 3.5 is supplied by the median nerve in the anterior side. On the dorsum of the foot, the same, which is supplied by the median nerve, it is supplied by the radial nerve. But the fingertips is supplied by the median nerve. Ulnar nerve always supply 1.5 digits. When you will see the forearm, it's very easy. Forearm, it is medial cutaneous nerve of the forearm, and the musculocutaneous nerve. And medial cutaneous nerve of the forearm, it is basically coming from the medial cord of the brachial plexus. And the lateral side is supplied by the musculocutaneous nerve. When you will come in the leg area, we know it's just showing ilioinguinal nerve, but basically this is iliohypogastric and ilioinguinal nerve, which is supplying this part of the inguinal area. Then we have femoral nerve. Femoral nerve has anterior cutaneous nerve of the thigh. Basically, it is forming the anterior cutaneous nerve of the thigh. Then we have lateral cutaneous nerve of the thigh. This femoral nerve, it is forming the anterior cutaneous nerve of the thigh, and it is giving one branch which is known as the saphenous. Saphenous is basically supplying the medial part of the anterior and the posterior aspect of the leg. Both sides, it is supplying the medial part. The lateral part is supplied by what? The lateral side is supplied by the common peroneal nerve. From the sciatic nerve, two nerves arises. One is the common peroneal nerve, the other is the tibial nerve. So common peroneal nerve is basically supplying all the lateral side of the leg. The medial side of the leg is supplied by the saphenous nerve, which is basically the branch of the femoral. And femoral is also supplying the thigh area also. So common peroneal nerve, it has three branches. One is the lateral cutaneous. The lateral cutaneous nerve, as the name indicates, suggests it is supplying the lateral part of the leg. Then we have superficial peroneal and the deep peroneal nerve. Superficial peroneal nerve, as we can see in the diagram, that the superficial peroneal nerve is supplying the dorsum of the foot, and the deep peroneal nerve is supplying mostly more on this big toe. The lateral side, it is supplying the lateral, which is the tributary of the S1. That side is supplied by the tibial nerve. Tibial nerve has sural branches, which is supplying that part of S1, and it has plantars also, medial and lateral plantar. So on the plantar, on the palm, on the base of the foot, you can see you have two divisions. One is the medial and the lateral plantar. Both these are also branch of the tibial nerve, and one is the sural. Sural is supplying the S1 area. So this is basically the dermatomal and the cutaneous nerve distribution. Now, from your side, contributions, discussion, anything.
Thank you very much, Dr. Ali, for the beautiful presentation. Just a few clinical correlates. The importance of the understanding the dermatome levels and tumoral distribution and the levels. It's important in especially spine injury or even in degenerative spine in with myelopathy in order to be able to assess the severity of the injury, level of injury, differentiating motor level from sensory level, and also determining neurological eventually, and develop calculating for trauma Asia impairment scale in patients with spinal cord injury. So that's important. And then the other thing um, is the rect laminae, particularly the substantial genitalosa and all that. They are important in the pain pathway and pain procedures, particularly, especially at the level of spinal cord, the rex lamina 2, which is a substitute for substantial genitalosa, modulation, just dorsal ganglion, and then pain modulatory procedures are also important. These are important in all this. Lesioning procedures can also be done at various levels in the pain pathway. And that's why it's important to understand the pain pathway. And this was already described during the presentation. Using the thalamotomy, lesioning the level at the level of the periopeductal gray matter, substantial granulosinosa, and even doing rhizotomies in some cases. And then, of course, DRES procedures, dorsal root entry zone lesioning procedures can also be done. So those are some of the important clinical correlates for this beautiful anatomic description that has been done. Yeah, those are some of the contributions I have. Thank you.
1 minute. One thing I want to ask. Basically, you are telling about, I also know about these pain procedures which we are using for the spinal cord injury, and sometimes post-op patient also, if they have post-op patient, then we also use these procedures. But basically, you are telling at the level of the substantia gelatinosa. If they are doing at the level of the substantia gelatinosa, that procedure is called myelotomy, basically, for those procedures. You are telling about that? Because we have rhizotomies, we have this dorsal root that you said, correct. But if they are doing this pain procedure at the level of the substantia gelatinosa, so that is the myelotomy, right? Correct?
Yeah, you can do myelotomies, yes.
Mm.
Yeah,
Mm.
but for the substantial genitalosa, I think there are procedures you can, particularly including PAG and all that. Those ones you do it by stimulating, you insert probes, and then
Mm.
lesion. I think you do it using stereotaxy. I think stereotactic
Mm.
placement of probes and all that. I think so. I've never seen them done, but I think I've read it quite number
Yes,
of
yes, because
times.
there is, yeah, that also in cases also when we will read about the functional neurosurgery, all these, so we will read about all these rhizotomies, and there is chapter also in that. I have also read few of them, not correctly, but there are different levels. Like you are telling periventricular gray matter also we will do at that level. What is, there are some indication for specific for each and every procedure. Okay, we will read it inshallah.
If there are any contributions from any other person in the house, so we can switch to
Yes,
case-based
case.
discussion.
Hmm.
Okay, so there are no contributions. Thank you everyone for coming out today. I hope the sessions are beneficial and we're learning from it every day. We are improving our knowledge and we are getting to know one or two things. I wish us the best during our trainings, and glad a lot of people came out for today's session, 9 participants at the end of the session, which was good. I hope we keep it up, we keep studying and preparing for uh sessions. Yeah, there's a recording for, I'll stop this recording so that we can have a recording for the Greenberg session separate from the other session. That's the case-based discussion session. So thank you everyone and have a good day. And just stay on the call while we while we stay on, and then I'll stop the recording and restart it, then we can start the other session. Thank you.